All right, so thank you all for joining us today. I believe we are live on Facebook for our second Center for Pharmacy Practice Innovation Lunch and Learn. Thank you to our panelists and our new moderator for joining us. I'm going to introduce him in a little bit, and thank you to our audience also for joining us as well. This is the topic today is too many meds, or polypharmacy if you're hip with the lingo. If you're not, as I am not, we are going to talk more about that today, just from a general public kind of level, so we all understand what we're chatting about. But without further ado, I'm going to introduce our moderator for us, and then we will kick it off. So Ace Calwood is here with us today. He is now a full-time facilitator of things such as this, and was previously Director of Communications for VCU Health Innovation Consortium. And he's a serial entrepreneur from what I understand, and does lots of different things, wears lots of hats, and one of them is moderating here for us today. So without further ado, I'm going to hand it over to you, Ace. Thank you for being here.
Madeline, much appreciated. We are talking polypharmacy today. I couldn't be more excited as I got kind of the brief from Shanika and Madeline, and thinking about the acute issue of having too many meds prescribed from multiple healthcare providers, so on and so forth. It just creates this really cumbersome existence as a patient. And we've got two of the best here from very own VCU, Dr. Zimmerman and Dr. Perrone. Kristen, Emily, thanks for joining us. Really excited to have this conversation with both of you.
Thanks for having us.
Absolutely. So I would love to do quick bios. We are just getting to know each other. But if I could get a quick background, maybe 30, 45 seconds from both of you on why this topic hits home for you, that'd be really helpful to kick us off. I think Kristen just gestured to Emily to go first, which is a weird thing to do virtually. We're like figuring out how we give each other cues. So Emily, how about you get us started?
Sure. So I've been working as a pharmacist for 12 years at this point, and have been working in geriatrics for that entire time. I think this is a topic that is near and dear to me for a few reasons. It's what I deal with most in my practice when I'm seeing patients, and I recognize the issues that can come along with having multiple medications and trying to manage that. I think also from a personal perspective, a lot of us work in geriatrics because we have had close relationships with older adults over the course of our lives. And I think knowing my own grandparents' experiences with multiple medications and hospitalizations and complex issues has really driven me to be cognizant of this just in my career as well. So.
Absolutely. Thank you for that. And Kristen.
Yeah, and I'll follow up and echo. I'll echo, most of what Emily said. I've also, been a pharmacist for well over a decade now, practicing in community pharmacy and ambulatory clinic side. Oftentimes with older adults in a very geriatric focused setting, but also within family medicine, serving an underserved patient population. And one of the things that I've seen is that polypharmacy is not something that's specific to older adults. We tend to talk a lot about older adults and really focus on that population, but it really spans a concern for all of the patients that we might serve throughout the continuum of healthcare. And so for me, polypharmacy is also not just a clinical issue, but it's also a policy level issue. What drives the decisions that we make as healthcare providers, and what sort of, forces us to maybe not spend as much time looking at the medications, or to feel compelled to add certain medications. And it's also a societal and social issue about sort of what are the pressures for us to want to treat patients, and for patients to want sort of medication related therapy, and how does that contribute to this continuum of potential inappropriate continued prescribing.
Yeah. So you've both just kind of given us some context as to why we're here. And I want to dig into first question, which is maybe the easy one, possibly the longer one. Why do we see folks end up with so many medications prescribed to them? Like, why do we have this polypharmacy issue? And of course, we'll get to deprescribing here in a few. Why do we have the problem in the first place?
I think there are multiple contributing factors. The biggest one, I think, is kind of logical. Individuals who have multiple medical conditions often require multiple medications. And so I think at its simplest, that's what we're dealing with. We're dealing with increases in individuals who have multiple chronic conditions. And as Kristen alluded to, that's across the age spectrum. That is not exclusive to older adults. I think we're seeing it in children and in adults and adolescents all across the board. And so I think it's more likely to occur in older adults, but we do really see this across the board. And so multiple chronic conditions yield multiple medication use. And so the more conditions that you're dealing with, the more medical problems, the more medications you're going to take. I think, so that's the part that warrants or yields appropriate polypharmacy, if you will, the use of multiple medications for justified reasons. I think part of the contributing factors, though, it's interesting. Most patients will go to the doctor's office or to see a provider expecting to leave with a prescription. That's kind of the indication that you've received care. You walk out with a prescription, therefore the appointment is a success. It's not that it's drug seeking. It's not that someone is looking for a drug to get their fix. It's really about that's the marker that we've kind of put in place, that people expect to leave with a prescription because it's normalized. And that's what we think is going to solve the problems that we have. And so I think providers feel a pressure to actually satisfy the patient in that way. And I think the other piece is that it's challenging to manage multiple chronic conditions. It's challenging to deal with acute short-term issues on top of that. And so a lot of times it takes a lot of time in order to appropriately discuss things like lifestyle changes. Quitting smoking can take a long time, multiple attempts to do that. If you're trying to lose weight, counseling on those issues. I think across the board, that takes more time, more effort on the part of providers and patients, and can be problematic. And so it's kind of this idea of a pill for every ill. We've become conditioned at this point in order to expect medications to be part of care. So I think Kristen mentioned it at the beginning, there can be appropriate polypharmacy, appropriate use of multiple medications, but there can also be inappropriate use of multiple medications. And so that distinction is really where we get into the crux of it, and where people like Kristen and I really live in terms of determining what is appropriate, what is inappropriate, and how can we help streamline so that patients can live lives.
Yeah, you just gave us so much right there, Emily, and I like some of the phrasing, right? A pill for every ill. We've got this societal conversation that if I'm going to a healthcare provider, getting a prescription says we made some progress, we did something. And of course, as I take those drugs, something will be fixed in me. And so it's a harder conversation to say, hey, you might just have to change the way you live. Stopping smoking or working out more or eating differently. I mean, those are things that for the instant gratification that we often feel societally, if you give me a little pill, that's great. And if I have to do something more than that, that's a harder thing to do. There's no value judgment on that, but the conversation is such that is our expectation now. So helping to understand some of the psychology of that is really useful, Emily. Kristen, you mentioned, living in the community pharmacy and family medicine world. I mean, you have seen this as well. I'm curious, how big is the issue across the board? I mean, do we have some data about how many folks are overprescribed medications?
Yeah, I mean, there's lots of data. Part of the problem with data related to polypharmacy, and I see Emily smiling and chuckling a little bit because she knows that we talk about this all the time, is that from a data perspective, we have a hard time defining exactly what is polypharmacy in order to get a good epidemiologic number as to sort of how common it is. Some pieces of literature will define it as a number, say more than 5 medicines, more than 10 medicines, in some cases more than 2 medicines, right? To really get at this idea of poly. But yet, other definitions of polypharmacy will be more medication than is necessary or is indicated or is appropriate, and is a bit more subjective in terms of nailing down what that is. So depending on which definition you use, the sort of prevalence rate or sort of epidemiologic perspective of, how big of an issue is polypharmacy, that marker sort of moves. We do know that, if we look at older adults in particular, over half of all older adults would meet that criteria if we used one of those numeric types of thresholds. So we do see that those rates rise as folks age and as they accrue multiple conditions, as sort of Emily was alluding to in the last response. So it can be a really high prevalence rate when you look at medication number. Now, when you think about this idea of medication appropriateness, it's a little bit harder to nail down. But for example, I work currently in a primary care geriatric practice, and I would say that of all of the patients that I see in a given day, almost 75% of them have at least one medication that may be considered potentially inappropriate if you were to do a structured review of their medicines. Now, the context of that may depend on sort of the patient-specific scenario, but it can really be something that's incredibly common and probably underappreciated in the patients that we serve throughout these different settings.
Yeah, yeah. So I want to run down that thread before we get to solving the problem. We've got two docs on the line and then myself, and I do not have nearly the alphabet soup after my name. So let's put it in layman's terms. I've got what one would say an inappropriate amount of prescriptions. How does one have inappropriate amount of prescriptions? Like, I have a drug that solves a thing and I have another drug that solves a thing. Talk to me about the implications of side effects and those drugs kind of counteracting each other. Where are the issues? Why is polypharmacy a problem? And maybe we get into some of the economic downside of that as well. It could be expensive, I'd imagine. But talk to me about the science of being overprescribed.
Yeah, I'll start off. One of the phrases that we use is the prescribing cascade. And
Okay.
I think of this almost as like a waterfall effect, where you have this downstream effect of what's happening from the prescription of one medication, that we oftentimes will have one medication prescribed, and then that drug is going to cause a side effect potentially. And that side effect may be treated with another medication. And so we're treating it almost as a new symptom, when in reality, it may just be a drug side effect. Now, in some cases, we can take away the original drug and then take away the side effect and eliminate the need for another medication to treat the side effect. But in some cases, the drug isn't necessary. And so, there is this downstream effect that happens where we're treating the side effect of one drug with another. And I think we hear this a lot from patients, that they're frustrated. I'm taking a strong pain medication, an opioid pain medication like oxycodone, and then I need to take medication for constipation, or I have stomach upset, and I'm having to take additional medications, and then that's having downstream effects. And so I think that's one of the big contributors to that inappropriate prescribing potentially. The other piece that we see is that sometimes there are medications that folks are on for long periods of time, and it's very difficult to determine at what point that drug is going to create a risk that's beyond the benefit. And so I think folks will be on medications for a long period of time, and they'll be safe and they'll be effective. And then at some point, there's a tipping point where the drug's just not, the risk benefit profile isn't what it needs to be. The risks are outweighing the benefits, but maybe the prescriber who's trying to consider whether or not to deprescribe, whether or not to take that medication off, if they didn't prescribe the drug originally, they may not feel comfortable taking it. We may also what they're experiencing. And so we're not able to know whether or not to take medications away. And sometimes I think there is also kind of a general unawareness of what some of the risky medications are in different populations. And so what are the problems that are being caused? So I think, when we're seeing patients, we're always thinking with, Kristen and I are always thinking with our polypharmacy hats, we're always looking at medications, but in a 15-minute appointment, it can take me hours to go through a medication list and to really make sense of it with a patient. And 15 minutes is never going to be enough. And so I think that element for someone who has 10 or 20 medications or more, that time piece can be really a challenge. So there's many, many more variables, and Kristen may have others that she wants to discuss, but those are just a few. And the other thing that I'll mention, you talked about the inappropriate prescribing. The other thing to consider is that it's not just what's being prescribed, it's also what's being picked up over the counter. It's the dietary supplements, it's the Tylenol PMs where Benadryl is hiding. And so I think there's all of these things that we're dealing with that go beyond the medication list that we can pull from the local community pharmacy. It's all of those other elements that are contributing as well.
Yeah. So, not to oversimplify a world you both live in, but it sounds like we've got to have a holistic approach to what meds folks are on and how those meds are interacting, and lifestyle and diet and all of the other pieces of one's health. That's really helpful to contextualize. Kristen, I saw you nodding emphatically through most of what Emily shared. Anything to add on that front?
Yeah, I mean, I would really echo Emily's point about this idea that oftentimes what's interpreted as being a new symptom is actually a medication-related side effect. And that's really tough for providers to sort out when they have, an average of 12 to 15 minutes to go through all of somebody's health concerns, and they may only see that person one time per year. So it's really easy for some of these things to sort of slip by and continue to sort of perpetuate over time. And in addition, when patients are seeing multiple specialists that are potentially in multiple health systems or multiple private practices, and those systems aren't talking to each other and that information's not getting shared, it gets really easy for, one hand to not know what the other is doing, and for somebody to really sort of feel devolved from the responsibility of prescribing or assessing whether that medication is still appropriate. I had a great example a couple of years ago of a patient who was taking a really dangerous blood thinner, who the neurologist thought the cardiologist was managing, the cardiologist thought the primary care was managing, and the primary care thought the neurologist was managing. So, when nobody knows sort of who's in charge, it's really easy to see how sort of this idea of inappropriate prescribing can be perpetuated, or even potentially appropriate polypharmacy, as Emily mentioned.
Yep. Yep. So, we all just kind of smiled at that last example, talking about a blood thinner, and, one person thought the other person. It's easy to be at 50,000 feet and say, oh, that's silly, right? Like, we've got some distance from a phenomenon, and we look at it and say, well, that's an easy fix, but it sounds complicated. So I want to jump into deprescribing. I'm going to go back to you, Kristen, and really, I just want to start with defining that term and then talking about when that might be appropriate to think about. And of course, we'll get into how to do it, which sounds like the really hard part. So let's start with the easy stuff. What is it?
Yeah, so deprescribing is this idea of thinking about, when looking at an individual's medication regimen, evaluating for each medication, do the, current or future benefits outweigh the sort of current or future risks? And so it's really about looking at the patient who's in front of you and determining, are those medications right for that specific individual? And in that, it's also thinking about, well, which of these medications, if they're not appropriate, should be stopped? In which case, should we reduce the dose potentially to the lowest effective dose that maybe has a lower likelihood of causing harm or side effects or other symptoms, or changing to an alternative medication if that medication's no longer ideal? And so for some patients, that means trying something different, a different approach. A great example, I had a patient just on Tuesday who I was seeing for follow-up. She was taking medications for her urinary symptoms. She wasn't sure if they were helping. She thought she might be having side effects like constipation and dry mouth, but she was really worried about, I don't know if this medicine is helping, or if it's not, because I'm still having these symptoms. What if my symptoms get worse if we change things? And we had a long talk about the fact that you might not always know if something's helping or hurting unless you try a different approach. And so this different approach sometimes means that, we try a reduced dose, or we try an alternative, or we try some time without it and see how things change. And changing a medicine isn't always permanent. Sometimes it means that we go back to sort of the way things were. We go back to a lower dose of a medication. And so it's this idea of really trying to optimize the medicines to the specific patient, to what's important to that patient, and what that patient's specific constellation of conditions and concerns might be.
Yeah. So it sounds like we've got two parts. Again, I'll oversimplify, but we've got the two pieces, right? We need to do the analysis. We've got to get some audit of current medications and who the person is. And then we've got to start pulling levers to see what solves the problem best. Emily, I know you see this with patients. Often, how practical is that? I mean, I'd imagine you can't just go to 0 on medications and then build a regimen back up, right? And so you've got to really think about everything across the spectrum and start tweaking things. How do you approach that? What's the prioritization? How do you think about that process?
If it was a one size fits all thing, we would be out of jobs. It's very much the unique to each patient. Every patient is a unique and special snowflake, and so is their medication list. And so we really have to dive in and look, and that risk benefit analysis is where it comes down to. So thinking about what are the necessary medications, what are the highest risk conditions that we're trying to manage, and what are the riskiest medications that we have on board. And so oftentimes, and it's going to differ per patient, but oftentimes we're looking for the drugs that are going to cause the greatest harm or have the potential to cause the greatest harm, but have the least benefit potentially. And so we're going to try to think about how can we pull those back a bit. And as Kristen alluded to, we don't oftentimes just pull a medication off entirely. We might decrease the dose and then get to trying to get that medication off. But I think, that risk benefit analysis is a tough one. But as Kristen mentioned, it's also about thinking about the patient's goals. And so for some patients, it can feel like if we're taking a medication off that we're giving up. And so that's another balance that we have to strike where, if someone has a problem and we're saying, well, could we take this medication away? They may feel like, look, you don't care about how I'm doing. You don't care about whether I have another stroke or I have another heart attack. And so it is a lot about educating patients and understanding where they're coming from, and then providing information about what we know of the medications. But this is all done in concert with the patient and with other providers. And so it really is a team effort with the patient, with the pharmacist, with the primary care provider, with the specialists, with the physical therapist, the nurse, it's everyone playing these roles individually and then coming together and trying to figure out what can we do to support this patient. So I think that it's very difficult to say without a drug list and a patient sitting in front of me, but it really is about thinking about what are the highest risk drugs, what are the most potentially problematic drugs, and what are we getting the least potential benefit from, and how can we rearrange. The other thing that I think of in terms of complexity is there something that we can do to simplify the regimen overall? And so when we talk about polypharmacy, we talk about number of medications most often. What we don't talk about is what does that look like in practice? What does that look like when you go home from the clinic and you then have to manage 5 medications, 2 which are inhalers that you have to take twice a day, 1 that you have to take before breakfast for your thyroid. And then you have another drug. I work with people with Parkinson's largely. The drugs that we use to treat Parkinson's start at 3 times a day, and so all of a sudden your 5 drugs becomes 15 separate administrations, right? 15 different times that you're putting something in your mouth, you're applying a cream, you're injecting yourself. And so that's also a piece that we have to consider. What are the challenges that the person is having at home that we can help to address by considering deprescribing? So it's not always just a straight, weighing the scales, risk benefit. It in terms of the drug safety and drug effectiveness, it may be a more practical consideration that we have to look at. So it really is, you hit the nail on the head. It's a holistic approach. We have to look at everything, and we need to make sure that the patient is invested in the conversation. Because I think, we can recommend things all day. If the right drug doesn't get to the right patient at the right time, it doesn't matter.
Yeah, but interestingly enough, I was talking about the 2 of you being the experts, which is absolutely the case. But I think about my work, part of which is negotiation, which doesn't seem like it's relevant to polypharmacy in any respect. But as I work with clients thinking about how they negotiate with another party, it starts with, what do I want? Right? What do I want, and what is my worldview, and how am I approaching the way that I engage with the world? And if we don't know that, I think, Emily, you framed that really well. If the patient isn't invested in the conversation, it's all moot, particularly because you both mentioned you get 15 minutes with the patient, sometimes once a year, and you've got a couple providers who do that. So you're herding cats all around a person. And if they're not bought in, how much can it matter? How much can we shift things? So I want to jump back to Kristen and talk about the practicality and the process of getting multiple providers on board to implement a deprescribing plan for a given patient. One that's got to be tough.
Yeah, so I think it really kind of depends on who is accessible to the patient. So everybody's healthcare access looks a little bit different, right? So some people have really robust interprofessional teams and some people don't. In an ideal world, you have a team-led effort that includes a pharmacist. And the data shows that team-led interventions related to deprescribing that incorporate a pharmacist are the most impactful. And that makes total intuitive sense, right? If we have all of those different parties speaking to each other and communicating, one person, usually the primary care provider, who's really steering the ship and making sure that all parties are on board, taking that ownership over the medication regimen. We have the patient as a member of that team putting input on sort of where should this deprescribing process go. We have the pharmacist who has years of medication expertise that they've learned about, how medications work, what are the risks, what are the benefits, what's the best way to take this medicine in terms of timing or administration, what's the best way then to stop this medicine. We spend so much time in healthcare education talking about, how to start meds and when to start and what to start, and we spend very little time relatively thinking about, well, when is it no longer appropriate? When do we think about stopping? And then how do we go through this sort of stopping process? So having the pharmacist as a member of that team, I think, is really important. And nursing staff, the auxiliary healthcare members, team members who are going to be helping with the monitoring process, communicating with the patient, being that sort of frontline face of follow-up. It's really important to make sure that it's a sort of team-led effort. And that can be really tough. And so making sure that there's a champion and that the patient is also an advocate for themselves is a great way to sort of start those conversations, get all of those team members sort of together and speaking the same language, and to demonstrate that this is something that is warranted and important for the patient's overall care is sort of the first step. Some patients don't have access to sort of a robust healthcare team. And so a great place to start in that case scenario is talk to your community pharmacist. Community pharmacists can also do some of these medication reviews and send some of that information over to the primary care provider to sort of start that conversation. If that conversation is determined to be important because the pharmacist is sending recommendations and the patient is asking me about it, that provider and that team may be more likely to sort of start the wheels in motion on thinking about whether or not these medications are appropriate and thinking about deprescribing.
Yeah, I want to run down a quick rabbit hole. This question was not thrown out already, but if I'm a patient, help me with some language to start that conversation. If I were a patient walking into a pharmacy, what phrasing do I use to say, hey, I need to talk about the holistic approach to my medicine, and you probably have most visibility as my pharmacist. Like, how do I get that conversation going tactically?
Yeah. I have questions about my medications, or I have concerns, or I want to make sure that my medications are right for me. Can you spend some time, sitting with me? So if you just ask a pharmacist for help, they'll love to talk to you all darn day if they can, right? So, just saying, can you help me sort through these medicines is a great place to start. Or I have questions, or I have concerns and I don't really know where to start. Or thinking about, if you're tech savvy, there's a whole bunch of online resources to help the patient sort of gather some of that information so that they can feel more empowered and in having that conversation. But, just ask, just say, I have questions, I have concerns. I'm not sure if these medications are still right for me. We talk a lot about what was good once may no longer be good now. And so, prompting that is, I'm not sure if these medicines are still the best for me. Can you help me sort that out? Is a great place to start.
Great. That's really helpful. Emily, I saw you pop off mute. Anything to add there?
Yeah, I think I wish there was a magic phrase, right? Like the password that gets you in with your pharmacist to look at your meds. And we do. And that's one thing that's inherently built in. When you go to your local pharmacy, you go to an independent pharmacy or family owned, you go to a chain pharmacy. When we talk about community pharmacy or retail pharmacy, that's what we're talking about. They are looking at your medications, but I do think that there is a difference between having that one-on-one conversation and saying, look, I'm noticing a difference. That's the other thing that oftentimes will trigger folks. I think it's a great idea, though, to have this conversation before there's a problem. But if there is an issue, I think that's another thing that might prompt discussion. And so even if you notice a change of any kind, I always recommend talking to a provider about that. And any, a healthcare professional that you trust, a pharmacist, a physician, your nurse practitioner, just to kind of start those conversations and have have a conversation just about what it is that you're noticing and thinking about. Maybe it's because I'm a pharmacist, but I really do think that any new symptom, any new problem should be seen as a drug side effect until proven otherwise. So guilty until proven innocent. And so I think that piece of it can really help kind of reframe. And it's not that drugs are going to cause every single problem that someone has, but I do think that if there's a change in your thinking and your clarity, in you're going to the bathroom, your bathroom habits, your eating habits, your energy levels, those sorts of things would be wise to be seen as a trigger to start to have some of these conversations. And it's not just the pharmacist that you can talk to. Like I said, you can talk to any healthcare professional. The chances of you being referred to a pharmacist are pretty high. But I do think that, we, like Kristen said, we want to have these conversations, but it's also difficult for us to gauge when you're at the drive-through picking up your prescriptions. How much of a conversation do you really want to have? How much of a conversation can you have at that point? And so just prompting that conversation. It's not that we're not interested. It's that a lot of times, people are in a rush and we want to be able to meet their needs there as well. But just, again, having that one-off conversation and, can you just help me? Can you just look over my meds and make sure that everything's looking okay? Is a totally reasonable ask. The other thing that I'll say, just to belabor this a second, is that when you go to multiple pharmacies, Kristen mentioned this earlier, when you go to multiple providers and they're in different systems, those systems do not talk. The same thing is true of your pharmacy. And that's a really important point to keep in mind. CVS does not talk to Walgreens. Walgreens does not talk to Rite Aid. Rite Aid does not talk to your local family-owned pharmacy. And so if you're getting medications from multiple pharmacies, it's important that every pharmacy knows every drug that you're taking, because that's how we establish or evaluate drug interactions. That's how we look for risky medications. And so that can also be a real challenge, because I think there's an unawareness of that. I think if Kristen and I didn't work in healthcare, I don't know that we would know that. And so I think some of that awareness of the challenges that people are dealing with, just from a practical standpoint, it's why conversations like this are important, because the more you can understand how the system works, the more you can understand kind of how a lot of times the patient is unfortunately asked to be the connector. But we're always trying to kind of help support the patient, but oftentimes it is that conversation that needs to be initiated by the patient, because again, provider sometimes thinks that another provider is doing it. And so, having that conversation, that prompting conversation can be really, really.
Kristen, it looks like you've got something to add. While you're adding, can you back to the kind of the tactical, can you share the best way you'd recommend a patient have a list of their prescriptions, their drugs? Like, what would be the best way to get all of that information in one place? And then, of course, add your commentary, because Emily just gave us some really good nuggets to chew on.
Yeah, I wanted to follow up on one point Emily made. She said, what is the sign that somebody should go and, talk to their pharmacist or talk to their healthcare provider? And she mentioned sort of a change in symptoms, a new symptom. But I just wanted to echo that, she said it's not always that something has necessarily changed or you feel different. Sometimes it's that you've had a recent hospital stay, ED visit, you've gone to a rehab, you've had some change in setting, you've had a new diagnosis or a change in your diagnosis. You've, had to make tough financial decisions about your medications, about which ones you can afford to take or not afford to take, or you're having trouble taking them, whether the schedule is really impractical and confusing, or, because you're forgetting medicines. So it's not just, if you're having a physical symptom, it's a constellation of different types of scenarios that might prompt somebody to have some of these conversations. And if you're going to have that conversation, you're going to have sort of the list that you bring to your healthcare provider, a list is extremely helpful, but a list only tells you so much, right? I think what's even more helpful is if somebody can actually bring in their medications, bring in those pill bottles, and not just the pill bottles, bring in, the eye drop container, bring in the inhaler box. Those types of actual physical tangible items give us additional information. Have you filled this 3 months ago, but it was only a month's supply? And does that clue me in that maybe, you might have some extra at home, or you might be taking it differently than what's on the label, right? Or are you, putting some medicines in the wrong bottles, and maybe there's a better way that we can organize or structure this. So bringing the medicines in is actually one of the most helpful things that patients can do. In addition to bringing in, if they have an organization system, what that is. Do they use a pill box? Bring that pill box in. Let me see not just what you're taking, but what you're taking when and how you're taking that. Because there might be ways that we can really simplify not just what you're taking in terms of medication number, but how you're taking those medicines, right? So another great example from clinic just this week, we had a patient who was taking meds 5 times a day, that she didn't need to, trimmed her down to 3 times per day, and her blood pressure came down 40 points and she was no longer dizzy. And it was all because nobody spent the time to not just say, what are you taking, but how are you taking these medicines? So it's not just the quintessential list, but it's the sort of implementation of that medication taking process at home. And also, if there are pieces of your medical history that provider might not have, or records that you have, or things that you can reflect on, like, well, gee, when was this started, or who started it, or, what am I taking it for? And do I really think it's been helpful? Some of that pre-reflection can also be really helpful to bring into, the healthcare provider, or thinking about, well, what is most important to me? Is it, my blood sugar control? Maybe it's not. Maybe it's not a number, but maybe it's the fact that I'm thirsty all the time. I'm peeing all the time. I'm too fatigued to play with my grandkids, right? And so think about what's important to you, because that will help us then make decisions about how we might modify your regimen to make it sort of meet those things that matter to you as a patient. So, there's all these different levels of what do you have the capacity for? If your capacity is just the list, then fabulous, I will take it. If you have the ability to bring in the pill bottles and the, eye drops and the inhalers, please, please do. If you have the time to, do the reflection, even better. And that'll sort of, every little bit of information that we have will really help us expedite the process and make sure that that regimen is really finely tailored to the patient who's sitting in front of me.
Emily's off mute. Talk to me.
Kristen and I have these conversations all the time. But I think we think a lot alike, and that's the nice thing. But I think, Kristen has alluded to reflecting, and I think it's a genius way of considering it. That what are the things what are your priorities as well, either before or during the appointment. But what it made me think of is this idea of documenting the conversations that we're having and taking notes and bringing those notes in with you. So we're not intimidated if you come in with a list of questions. We want you to come in with a list of questions. And that's how we're best able to meet your needs. I think of my own experience in healthcare. I walk into my primary care provider's office and all of a sudden I've forgotten what my problems are. Like, I don't remember why I'm there. I can't, right? And then I walk out and I'm like, oh, those 14 things I wanted to talk about, totally forgot. I guess I'll wait until next year, or maybe call if they're really concerning. And so I think that's another piece where it's okay to go in with notes and with your own priorities. And then it's equally important to walk away with notes and with ideas, because again, you walk out and then you forget what was discussed. What am I supposed to do? When am I supposed to take that? And so, we should be writing these things down. We should be sending you out with information, but sometimes that's not the information that you need or the things that you took away from the appointment. And so whether that means bringing in a friend, a family member, someone who can take notes while you're talking or can help trigger what are some of the things that you wanted to discuss, or if it means you bringing in a notepad and jotting some things down, that again, it shows investment in your health. And I think it also helps you leave a little bit more empowered, when you've gone to a provider's office, and making sure that you're getting the services that you want, that you're getting what you paid for, and that you're getting, even if your copay is zero, there's still something that you've paid for, right? In some way over time. And so I think just making sure that you're getting out of the appointment what you need, And following up also if you need to. If you need to call, if you forget something, if you didn't take notes, if you lost your notes, you're allowed to call and follow up and ask questions. So definitely we don't want to put it all on the patient, but it's really hard for us as providers to know where the gaps are, where are we not connecting. And so the more that we can kind of help empower patients to take notes or involve other people if they need to, the better off I think we're all going to be.
I love that. I was reflecting as you were talking, and I'm a relatively healthy young man, not on a ton of drugs yet, but one day I will be, and I will be finding one of you to make sure I'm taken care of. It can be daunting though, right? There's some dissonance. I want to be invested in my healthcare, but at the same time, these are the experts and they should tell me what I don't know. And there's a lot that I don't know. And so the idea of being able to just jot notes and be engaged and invested is important. It sounds costly to sit with a pharmacist and hand over all of my pill bottles, my inhaler box, and take that time. Let's start to talk about the financial impact of deprescribing. Is that a costly experience to sit with my pharmacist? Is that something that goes off to insurance? I mean, just like the practical of getting my healthcare sorted appropriately. I don't know who that should go to, but I'd imagine one of you. There we go. Kristen raised a hand. Ding, ding, ding. Talk to me.
I just wanted to, say one thing, Ace, and I'll segue into the cost thing. You hit the nail on the head when you said, it's really hard sometimes for patients to sort of pinpoint what, should be changed or what should be stopped. And one of my colleagues has this really great analogy for the data. The data shows us that, if we were to survey patients, like 90% of patients feel like, at least one of their medicines should be stopped if they, that they would stop taking a medication if their doctor said they could. And then if you ask them, well, which medication, do you think is problematic? They can't identify one. So it's almost this idea of I really want to clean out my closet, right? And I go and I try to clean out my closet, and then I get to that old prom dress, that old biddy in the back, right? And I can't part with it. It's hard sometimes when we're attached and we're the patient to really identify which of those sort of medicines or prom dresses we might want to get rid of from that closet. And I love that analogy. It's a really hard thing to do on your own as a patient, which is why engaging with the healthcare provider is so incredibly important. In terms of cost of having one of these visits, it should, ideally take place within the context of existing medical care, within your healthcare provider visit. So it shouldn't be associated with an additional cost above, which you would pay for a normal copay to see your primary care. If you wanted to sort of work with your pharmacist, we talked about some community pharmacists can do medication reviews, and those are, covered by the insurer, the prescription drug insurer, so that there's not an additional cost that falls on the patient for that service. And what we see is that studies find that deprescribing results in cost savings all around, particularly for the patient. But we don't just see cost savings for the patient, we see cost savings for the health system, and we see for the patient improved clinical outcomes and improved quality of life. So we often think of cost as financial and sort of these sort of financial trade-offs, but it's also, how do I feel? That's associated with, in a sense, sort of a cost, right? Cost benefit trade-off. And if I feel better, that's worth that investment of my time, and maybe an additional visit to see my primary care provider if for the next decade I'm going to feel better.
Mm-hmm. So as far as having conversations about medicine, I didn't expect to hear some Marie Kondo thrown into there. Does this medicine spark joy? It's just like cleaning out our closet. No, that's real, and it's hard to know what, and so we kind of have to have the conversation with our healthcare providers, right? Like, we have to engage in order to know what's in our closet and which ones are the prom dresses that we're nostalgic for but don't actually need, so on and so forth. I mean, there's a holistic conversation to be had there. So I'm looking at time, and I know we've got a couple questions coming in, but I want to pivot to, what if deprescribing isn't the case? What if that's not what's necessary? It's simply managing. And Emily, I think you shared this experience of having a million things and taking them at different times, and that is cumbersome in and of itself. Even if we've got all of the right medications in our regimen, how and when they're being taken can be cumbersome. So is that something you all think about as well?
Oh yeah. I think there's a really good, there's an image that I have in my mind of what does the medication list look like for the provider? And it's long and it's a lot, and we have to navigate that. But what does it look like for the patient? And it's just drugs everywhere. It's pills, and it's inhalers, and it's creams, and it's dietary supplements, and it's, and I think that's the element sometimes that's disconnected between the clinician, the healthcare provider, and then that patient at home. Kristen and I have both been in home healthcare at one point in our careers, and it is entirely different to see a patient in their clinic and then to go to their home and to see how they live and to see how they manage things. And so I think that if we can't take medications away, and in many cases we can't, it's a risk to the patient. You might not be able to feel your cholesterol building up, but it might be happening. And so that's, we can't necessarily take that drug away just because you don't feel it benefiting you. But I think that if we can get back to that idea of what is it that you take, how do you take it? What are the things that are making you feel limited in your day? Are you having trouble remembering to take your medications with you when you leave the house? We need to be thinking about medication adherence and that kind of medication taking behavior in a holistic way again. And so thinking about what are the changes that we can make to help you maximize your medications, even if it's a long list. How can we make it simple for you to adhere to the medication regimen that you've agreed with your provider is what you're going to do. And so that may mean, I keep saying pillbox, that may mean having some sort of organizational tool, but that's not a fit for everyone. The potential exists that we need to talk about your belief system and why you think you're taking your medications, and how much do you really believe in modern medicine and in prescription drugs. It might mean that we have to talk about things like reminder systems. So do we need to think about setting alarms on your phone? Is it something that you're forgetting to do? It's unintentional. Is there a cost consideration that's keeping you from filling your medication once a month when, like Kristen said, maybe you got something filled for a month, but that was 3 months ago? Where, are you trying to extend the life of those drugs by splitting them in half? And so all of those little nuances are the things that we need to think about. We need to get to the bottom of it, because a pillbox is not going to fix it for everyone. An alarm is not going to fix it for everyone. And so we need to be getting to the root of it. And we're saying, look, this is the best we can get your medication list looking right now. How can we help support you and help you make sense of this without, again, feeling like you're tied to your drugs all day, every day? Because I deal with patients all the time who feel that way. And that's a really, really tough position to be in. You're going on vacation, you forget your medications. What do you do? And so I think, all of those things we need to be considering. And again, not a one size fits all, but that's usually where my mind goes. Once we're at the list, this is the list as we're going to have it for now, for this period of time. What can I do to support you now in order to make this manageable for you when you walk out my door and go home, where you spend 99% of your time, right?
Kristen, I want to get some follow-up thoughts there. I know you are the expert in deprescribing. Do you end up in circumstances where you say, hey, we don't need to cut anything from your regimen, we just need to manage it a little smarter?
All the time, Ace. I think we know that people interpret medication directions so differently. And, sometimes people take medications in a more complicated way than they really need to. And, medications fit into different people's lives very differently. And so sometimes, there really isn't anything that we can reduce. But, as Emily mentioned, there might be a way that we can reduce sort of how burdensome that feels for a patient, right? By tweaking some of those nuances of how are the medications administered, what is the sort of schedule, what is sort of the routine with medication taking, what is the understanding that somebody might have, what is the prioritization of, if finances are tight, sometimes we have the conversation of, okay, well, what are the core medicines that that you should always take? And then what are the ones that, if you can't afford them, that are okay to go without, or are okay to ration, or are okay to split? And so sometimes it's those helpful conversations that can actually improve quality of care or maintain somebody's quality of care through these sort of changing times in their lives, without having to mean that medications have to be pulled back or deprescribed all the time. So there's benefits to having the conversation, even if, after doing all of the sort of examination of the medication regimen, we don't find a medicine to stop. There's a lot that we can do to make that better for the patient and improve their outcomes.
Mm-hmm. So I'm percolating on the probably misconception about pharmacists, particularly that my doctor decides what I need and prescribes me something, and then I go to Walgreens or Rite Aid or CVS, and there's a person who's required to have a degree behind the counter, and they just hand me stuff, right? And so, everything that I've heard in this conversation says pharmacists ought to. It's almost requisite that my pharmacist is an integral part of my care and has visibility into other aspects. So we've got a question in the chat. I think we've talked about it already, but it seems like this is a question that I ought to go to my pharmacist with. If I've been prescribed from one healthcare provider who may not have visibility into all of my other providers, if I'm concerned about needing another drug, or perhaps I've been prescribed one, what would you say to me if I'm concerned that I also need another drug to manage the side effects of the new thing that I've been put on? I think we've touched on it a little bit, but again, the question explicitly is, what would you say to someone who's concerned about needing another drug just to manage one drug's side effects?
Do you really need the first drug, or is there a better alternative to the drug that's causing the side effects? And in some cases, there isn't an alternative. And in some cases, you do need that original drug, and, we do need to find a way to manage the side effects. But I would say that's probably on the rarer side, maybe 25% of, all scenarios. And there might be an opportunity to mitigate those side effects through a medication change, a dose reduction, an alternative medicine of the same type that gives you the same benefit without the same side effects, or a way to manage that symptom that doesn't require the addition of a new medication that sets you up for more medicines, more out-of-pocket costs, more potential side effects, and more risk. So have that conversation with the prescribing provider, would be, I would say, paramount, as well as, who else is involved in your care. Mention it to your pharmacist. Is this something that I should probe a little bit further? Mention it to your primary care provider. I've been wondering, or I've been curious about this. But, always bring it back to who the initiating provider is as well, and making sure, again, that all parties are in the loop, which is something that in healthcare, we should be doing all the time. If you bring it up to me in the pharmacy, I'm going to certainly contact your primary care provider and or the prescribing provider to make sure that everybody's in the loop, aligning that care and those care decisions that we're making.
Absolutely. So I want to do a time check. We've got about 10 minutes left. So for those folks on Facebook, make sure you're sending questions in chat. Make sure if you have something percolating, send it to us so we can get that covered in the last couple minutes. And I think Madeline is keeping an eye on chat to grab those questions. For Kristen and Emily, as we spend our last, I think, 8 minutes together, if I'm thinking about my current regimen of medicine, if I'm thinking about deprescribing, if I'm a patient managing life and my medicine on top of that, where would you tell me to start? Are there resources, reading? Are you sending me to WebMD? What would you recommend that I do out of the gate to just get a better understanding of where I am? What's my foundation?
So I'll say that if you're online savvy, I'll sort of start with tech references, and you're really you're on Facebook Live, so you have some tech savvy if you're listening to this. There are a bunch of actually really good online resources, two that I will recommend explicitly on this session. One is deprescribing.org. They have a bunch of great resources for patients about what is deprescribing? Is it right for me? How do I know? know. And they zero in on specific, case examples or specific types of medicines in particular that may be really helpful for patients. The other is a website called PIMS, PIMS plus, one word, .org. And that website allows you to actually enter in a list of your medications, and it'll sort of see if you might be a good candidate for a medication review and connect you with, folks or resources in your area to help you get that medication review that you need. So, if you're on Facebook Live and you're tech savvy, those are two resources to check out.
So Kristen, let me make sure I got those. We got deprescribing.org, and PIMS Plus, which my autocorrect changed to pimples.org. PIMSplus.org and deprescribing.org. Great resources to start with. Okay, Emily?
And I'll clarify. Yeah, the only thing I was going to clarify is the PIMS phrasing is potentially inappropriate medications. So there's actually a meaning behind it. It's just that it's our lingo, right? Like this is the language that we speak. And so, but that's what it stands for. It's not like, I guess there's PIMS cups, right? It's not like the drink, it's potentially inappropriate medications.
Last night, so yeah, it's all relevant. I love it. Potentially inappropriate medications. PIMSplus.org and of course deprescribing.org. So that's for the tech savvy. If we're less tech savvy, if somebody helped us get set up on Facebook Live today, but we were not on the internet often, where would you send me?
I mean, I think my natural inclination is, again, those in-person conversations, or calling ahead even and saying, look, I'm curious if there's a time that we can set aside to talk about XYZ, or I'm coming into my primary care doctor's office and when they call to even verify that you're coming, you can always mention, like, I'd really like to talk about my medications at this appointment. I think those sorts of things, if you can have those in-person conversations, it's going to be that much better if that's what you prefer. I think those in-person conversations or those phone calls. And again, just being aware of what are some of the things in particular that you want to talk about. And if there's nothing in particular, that's okay too. We can kind of help guide the conversation. But one thing that I'll also mention is creating that list is very helpful, especially if there's a planned hospitalization, if you're seeing multiple providers. And so taking that with you where you go when you're seeing different providers can be really helpful. Like Kristen said, having those physical drugs and being able to have a full conversation is going to be the best. But even if you can just take that list with you, and have someone else essentially do the PIMS Plus evaluation, because that's what we're trained to do. I think, just being open to that and being willing to have that conversation. I wish we didn't have to ask patients to advocate for themselves as much as we do. But I think that, that piece, we can't read minds, unfortunately. And so it would be great if folks could help, help us help you. And actually, I think the administration times on that list is a big one. Kristen's big on that as well. And so making sure that
Tell me more about administration times.
Sure. Yeah. So when does the person take the medication? So 3 times a day, once a day, twice a day. That's helpful for us to know, but it's also helpful for us to know how you interpret that, like Kristen had mentioned. So if you can tell me you take your thyroid medication at 7, you take your medication for 3 other conditions at 9, you take your medication for your cholesterol at 11 p.m. I mean, when we actually sit down and have those conversations about when do you actually take your medications throughout the day, that tells us a very different picture. And so some folks will actually organize their lists. They'll have the drug lists, and then they'll have I take simvastatin 20 milligrams at bedtime. But if you can say, I take it at 9 p.m., that's helpful for us to know. We can kind of put that in the picture with the other drugs that you're taking if you give us those times. The other thing that I'll see done is individuals will actually make their lists by time. So at 7 o'clock, these are the drugs that I take. At 9 o'clock, these are the drugs that I take. And that's a way for us to visualize even a little bit better what it is that you're doing and how you're setting that up and how you're interpreting those recommendations. Because some folks will, they might read somewhere or hear somewhere that they're not supposed to take multiple medications together, or they're not sure if they should take it with food. And so they separate it out. But we're better able to then help you navigate it, simplify, if we know how you're doing it. Because oftentimes when you ask that question, when do you take this, you get a very different picture than I take this 3 times a day. And Kristen unmuted, so.
Well,
Yeah.
no,
That's
Kristen,
good
you want to add something? We've got to manage time, and I've got 2 questions for
Okay.
from folks.
All right.
The easy one, rapid fire. Can we do it in a sentence? Do all pharmacies offer deprescribing services?
No. I would say that not all pharmacies offer deprescribing as a service. If you're thinking of pharmacies in the term of context of chain pharmacies, all pharmacists in all settings have the ability to review somebody's medications. But whether they offer it as a formal service that you come in and you make an appointment for, I would say no. So that's why Emily mentioned it's important to call ahead and say, hey, or say to your pharmacist, can we set up a time to talk about these things? That's part of what's ingrained in a pharmacist's job, not necessarily a separate service. The pharmacist in a community setting may not be able to say, okay, well, you're going to stop this medicine, right? But a pharmacist working in a clinic environment may have the ability to make those changes themselves. So the settings in which pharmacists practice may mean that their roles are a little bit different, but it's not like you can just say, hey, pharmacist, I'm going to pay you $20 and, we'll go through how to deprescribe my meds.
All right. Thank you. Last question, and this is a heavy one. When beginning a new medication, can a person be prescribed a partial dose before filling the entire script to be sure there's no side effect? It sounds costly to fill a full script, and finally you got to stop it. So I see a nod from Kristen. Thoughts on that, either of you?
Yeah, so this is what I do all the time when I start a medicine is we often will do a partial fill to make sure that it's going to be well tolerated and effective for the patient.
Yep.
And move forward or backward from there because medications can be incredibly expensive. And we also, in addition to medicines being expensive, don't want patients having, hundreds of pills lying around that they're no longer taking around the house. So it's also about minimizing the amount of, excess medicines or waste that somebody might have if a medicine doesn't work.
Awesome. So we are at the top of the hour, and this has been a wildly informational session. Dr. Kristen Zimmerman, Dr. Emily Perrone, thank you both for joining us today. And Madeline, of course, thank you and the rest of the folks over with you and Shanika for coordinating. This has hopefully been helpful and enlightening for all parties involved. So thanks again to all.
Yes, we're getting lots of positive feedback. So thank you. Thank you both for sharing your intel with us. And thank you, Ace, for moderating and just kind of carrying this conversation. It's been really good. We really appreciate y'all's time. Any last thoughts real quick before we call it a day?
I would just say, just put in the chat box to Emily in all caps, we could do this for hours. This is one of our favorite things in the world to talk about. So if folks have questions, you can always reach out to Emily or myself and ask them, and we would love to talk to you all about them. So thank you everybody for tuning in. Thank you, Emily. Thank you, Ace, for giving us this opportunity to all come together. This has been a lot of fun.
Absolutely.
That's all I've got. Kristen speaks for both of us.
Sounds good. Well, thank you both. And we do want to share with our audience that we will be having another Lunch and Learn next month on April 16th. Same time, same place. We'll be talking about blood pressure with a couple of our pharmacy professors and some community pharmacists as well, hopefully. So thank you all and have a great weekend.